The mother is 32-year-old second gravida with 2-year-old normal child. The given picture is of the fetal heart at 20 weeks and rest being totally normal. I am giving the 4-chamber and 3-vessel tracheal view in B mode and on Doppler. You can also go through the video. Please focus your eyes to see the ventricular asymmetry and the deviation of the cardiac apex in 4-chamber view and see how is the 3-vessel tracheal view. Here the heart is being formed by the larger right ventricle, which is forming the cardiac apex in the B mode, which is better appreciated on Doppler. The finding is highly characteristic of hypoplastic left heart syndrome, with the left ventricle being significantly smaller and appears narrowed with no VSD. There is no evidence to suggest any transposition of great vessels, or there is no unbalanced atrioventricular septal defect. I repeat here, the larger right ventricle forms the cardiac apex and the left ventricle is smaller and narrowed with no VSD. We can clearly say there is no transposition of great vessels and there is no unbalanced atrioventricular septal defect. You can also see situs solitus with the heart and stomach being in the same side in the given video. These findings are nearly pathognomonic of hypoplastic left heart syndrome with small left ventricle showing thick echogenic wall by fibroelastosis. The other important findings are also noted with thick immobile mitral valve with no motion on color Doppler, and there is retrograde flow in the aortic isthmus. All the above findings are typical for classical type of hypoplastic left heart syndrome, which forms the 60 to 70% of hypoplastic left heart syndrome. So this classical hypoplastic left heart syndrome is diagnosed after 20 to 24 weeks usually, depending on the fetal lie and maternal abdominal wall. But there are some pitfalls if the hypoplastic left heart syndrome is not classical. One common pitfall even in experienced hands is when it could have been initially diagnosed as mild aortic stenosis during anomaly scan, but at 8 months turns out to be either critical aortic stenosis or hypoplastic left heart syndrome, or this could be detected only postnatally. Okay, now we talk about the mimics of hypoplastic left heart syndrome. One is wide range of double outlet right ventricle. The other one is unbalanced atrioventricular septal defect, which are easy mimics but might be distinguished by the experienced hands, especially if the fetus shows changes of situs ambiguous, and that too after 20 weeks, because it might be difficult before 20 weeks. Real diagnosis with small left ventricle could be due to interrupted aortic arch or coarctation of aorta or critical aortic stenosis. I am giving the table to distinguish between the hypoplastic left heart syndrome and the severe coarctation of aorta and the critical aortic stenosis. Now you can see that the left ventricle size will be very small in hypoplastic left heart syndrome, and it will be smaller in width but not in the length in coarctation of aorta, whereas it will be dilated and circular. That's very important in critical aortic stenosis. Now we'll go to the cardiac apex will be built by right ventricle in most of the times in hypoplastic left heart syndrome, as in our case, which is classical. And the second, the coarctation of aorta is always built by left ventricle, but critical aortic stenosis usually built by left ventricle, but sometimes due to the asymmetric or non-classical type of hypoplastic left heart syndrome with critical aortic stenosis might be variable. Now we'll go to the left ventricular wall, which is always echogenic in the hypoplastic left heart syndrome and most of the times in the critical aortic stenosis, but it will be always normal in coarctation of aorta. We'll go to the contractility of the left ventricle, which is reduced in hypoplastic left heart syndrome and in critical aortic stenosis, and it will be normal in coarctation of aorta. Then we'll go to the mitral flow, which is in nil or subtle flow in the hypoplastic left heart syndrome, and it will be reduced in critical aortic stenosis, but will be normal in coarctation of aorta. Now we'll go to the VSD. Usually in classical type of hypoplastic left heart syndrome, it will be absent, whereas it might be occasionally seen in the rest of the two. Now we'll go to the aortic valve, will be atretic in hypoplastic left heart syndrome, severely narrowed in the critical aortic stenosis, and it will be patent in coarctation of aorta. The aortic arch will be variable in all these things. Then we'll go to the aortic systolic flow, will be absent in hypoplastic left heart syndrome, and it will be having antegrade flow in coarctation of aorta. In the critical aortic stenosis might have either minimal or no flow. The most important one is the aortic isthmus. It will always have reversal flow in the classical type of hypoplastic left heart syndrome, whereas it will be having antegrade flow in the coarctation of aorta, and it will be either antegrade flow or minimal reversal flow in the critical aortic stenosis that might be seen even in the severe coarctation of aorta. Now we'll go to the theoretical parts of hypoplastic left heart syndrome, which has two forms. One is classic form of hypoplastic left heart syndrome, as in our case, with visible left ventricle showing globular shape with hyperechoic valve, having poor contractility by dysplastic mitral valve and critically stenotic or atretic aortic valve. The other form is severely atretic portion involving atresia of both the mitral and aortic valves with nearly absent or severely hypoplastic left ventricle, which is poorly visualized and has got the worst prognosis. But this differentiation is now less bothered, as the prognosis is indicated by the anatomical and pathological changes in the foramen ovale and in the pulmonary veins in the fetal echo, which are better assessed on Doppler at or after 24 to 28 weeks. Okay, here to conclude, the specific finding of classical hypoplastic left heart syndrome is the dilated right ventricle becoming the cardiac apex with very small, thick echogenic left ventricular wall due to dysplastic mitral valve and critically stenotic or atretic aortic valve. After this session, never miss the diagnosis of hypoplastic left heart syndrome, especially after 24 weeks, because even now, almost 30% of hypoplastic left heart syndrome are missed antenatally and diagnosed only after delivery. Okay, that's all, dear colleagues. I'm ending the session. Thanks a lot for your patient listening, and it will be grateful to have more like buttons from you, and it's a great pleasure and happy to see your review and your thoughts in the comment section. Thank you very much. We'll meet you again. Bye bye. Take care.